population fear for a whole host of political and economic reasons. One of the more recent things is that it's being utilized by Big Pharma to sell stockpiles of drugs that they've developed, for example, oseltamivir and remdesivir. The Illuminati agenda has always been there. Are there, in fact, potential herbal treatments that are being suppressed by Big Pharma? And I mean, just from our own Islamic point of view, or from our community point of view, things like black seed oil and sumac and all the herbs, the Madagascan example of the potion that they're developing with artemisinin are all out there, and whether those in fact have been studied further in order to prove that wrong. And is it just another flu viral infection? Or, is everyone just making a big fuss about nothing, considering in South Africa that we have at least 10,000 deaths from just the flu itself per annum? So what is COVID then? If those are all the myths, what is it in fact? It's a disease caused by a new strain of coronavirus. The CO comes from corona, the VI from virus, and D from disease. So that's where the COVID came from. And formerly it was referred to as 2019 novel coronavirus or 2019 nCoV. It is predominantly a respiratory illness and can range from asymptomatic to severe and fatal. And we all know it's largely droplet spread. It was first identified in Wuhan city in Hubei province in November 2019. It was declared a world emergency in January 2020, and then a pandemic only in March. So here's the facts, the virology facts. It is a zoonotic origin virus and shares 96% of its genetic similarity to that of bat coronavirus. So to a large extent, that explains, or removes the myth about it being lab created. Whether the zoonotic virus, in fact, was genetically then modified further, the jury is still out there. There are 4 strains of coronaviruses which circulate freely amongst humans. 2 we know about already. One was SARS-CoV in 2002 and MERS-CoV in 2012. And even though they were new outbreaks, neither of those caused significant mortality amongst populations that they were spread in. It is transmitted from person to person via respiratory droplet, as I said, and it's also from contact from infected surfaces or fomites. The droplets can spread for up to 1 meter or more, and largely driven by coughing, sneezing, or even airflow from air conditioning ventilation, which can then spread it further than normally the meter. It can survive on surfaces for up to 4 days, and those surfaces that are infected or contaminated are known as fomites. And you then touch those surfaces and touch your eyes, nose, and mouth, and then spread the infection as that way. Aerosolization is one of the things that's been controversial from the outset. It still remains a possibility. There's no definitive conclusive evidence which shows that it is. But it also then depends on the size of the particles. So particles less than 5 microns can potentially be aerosolized. And particularly when you're managing patients in ICU or in a high care situation where you're using or doing procedures that might generate aerosolization as one of the risks. So is it shed in stool? And that there may be fecal oral transmission? We're not quite sure, although the virus has been found from swabs in about 29% of positive patients. So there potentially may be fecal oral transmission. Vertical mother-to-child transmission still hasn't been shown. We have had 1 or 2 incidences where newborn babies have died, but it's been shown to have the baby been infected post-delivery. So how do they work? They express a transmembrane glycoprotein, which are the spiky bits that we've all become familiar with on all the pictures, and that's why it's called corona. This allows the virus to attach and gain entry into the target cells, and they gain entry or binding to an ACE2 receptor site. So viral replication occurs then within the target cell using RNA polymerase, and the ACE2 receptors are expressed predominantly on type 2 pneumocytes, upper respiratory tract epithelial cells, and intestinal enterocytes. So that, again, a potential reason why you may have viral shedding in stool. The ACE2 receptor sites is what caused a huge amount of controversy initially with patients who are hypertensive on ACE2 inhibitors, and there was a big rush for people to then get off those ACE2 antihypertensives, but that has been shown not to be necessary subsequently. So clinically, there's usually an incubation period of 4 to 5 days. 75% of infected people will develop symptoms in the first week, and less than 1% will develop symptoms after 14 days. So if you're not going to develop symptoms between that first and second week, it's unlikely that you will. 80% of cases usually develop an upper respiratory tract infection, and the majority of those people will recover. 20% of those develop dyspnea and require hospital admission, usually by the beginning of the second week. A very small percentage, and it's ranging between 1 and 2% of people, will develop life-threatening disease or end up in ICU. The pathophysiology is usually diffuse direct or indirect damage to the alveoli. And again, it's by binding to the pneumocytes in the lung. And early symptoms of severe hypoxia with preserved lung compliance can appear. And usually when you see these patients, they are symptomatically not as distressed if you compare to the level of their hypoxia. So they may come in with sets of 70 or 80, but clinically they don't look that distressed. Things like cytokine storms, myocarditis, cardiomyopathies, DIC, and multi-organ failure are usually indications of severe disease and inevitable fatality in many of those patients. Symptomatically, they present with a fever, cough, dyspnea, unusual symptom, anosmia, sore throat, myalgia, GIT signs and symptoms, and then on the more severe spectrum, meningitis, Guillain-Barré type syndromes, and encephalitis. And if you look at the first few symptoms, it's pretty much what we would experience with any normal flu-like illness. And going into winter, which is generally our flu season, it's going to become more and more difficult to differentiate the two. 17 to 30% of patients are usually asymptomatic, but they can still be viral shedders, and that's the challenge in terms of trying to control the disease. The symptomatic ones, easy, the sick ones, easy, but the asymptomatic ones have very little that they complain about, so very difficult to isolate them and prevent them spread the disease. However, they have found that both laboratory and X-ray changes are present in many of those asymptomatic patients. From an ICU point of view, they've classified the COVID infections into two phenotypes, and it's just basically to kind of guide the clinicians in ICU on how to manage these patients. So, for example, an L phenotype patient would avoid mechanical ventilation and just give them proper oxygen therapy with high-flow nasal cannula, whereas the H phenotype patients would respond to ventilation with PEEP, with proning and protective lung ventilation. So how do we manage these patients? Everything except oxygen is all still under investigation, and the jury is still out there. So no other proven therapy for definitive management except oxygen to date. So as we all know, hypoxia is a major issue. So oxygen administration with proning, preferably in an awake or self-prone patient, high-flow nasal cannula, helmet CPAP, and all these procedures, again, are associated with potential aerosol generation, and additional precautions have to be taken. Initially, it was thought we need to intubate early, and there was a big run on ventilators and trying to get people into ICU on a ventilator. More and more, it's becoming evident that the problem is not a ventilation problem, it's an oxygenation problem. So if we can get the oxygen to the patient, using whatever means other than a ventilator, it's probably better. However, there is a subset of patients that do need ventilation, but they're associated with poorer outcomes. As far as drugs and medication are concerned, there have been a whole host of drugs that are still under trial. Essentially, there's been no proven drug that has been shown to work 100%. So initially, the first group of drugs that came to the fore were chloroquine or hydroxychloroquine and azithromycin, used alone or in combination. That to a large extent has been shown not to be as successful as it was originally thought. And then Aluvia and Kaletra, or lopinavir-ritonavir combination, which is on our HIV regimen treatment, was again, because of its antiviral nature, trialed as a treatment for COVID, and again hasn't been shown to be too successful. The latest drug is remdesivir. Remdesivir was a drug developed by Gilead, largely as a hepatitis and Ebola treatment drug, and was unsuccessful as an Ebola drug, essentially, and has been shown, again, because of its antiviral properties, to have some kind of effect. The study that the use of it was based on was essentially one out of China, which showed, they said, 31% of an improvement. But when you actually went into the study, the 31% was a very small number of patients. I think it was 12 or so patients. And what they in fact found was that there were no changes in clinical outcomes, in mortality, but in fact, the only positive outcome was that there was a decrease in the number of hospital stay days. So I think it decreased from 16 to about 11 days. So there's a huge run on it in the States at the moment, where President Trump has basically said it must be distributed everywhere, and they've already created a shortage of the drug. But there are no definitive trials that have proven to have been successful. Tocilizumab is a monoclonal antibody, and there's been some success, particularly if it's used as or just before the patient is likely to go into a cytokine storm, and seems to have shown some positive outcomes. As I said, azithromycin largely used in combination with the chloroquine and the Kaletra or Aluvia. And then, of course, initially everyone jumped on the use of Tamiflu. In fact, Tamiflu, when the COVID infection first started, the same company, Gilead, had a 6% increase in their sales and their share prices, simply because there's a huge, from the last infection with the COVID virus, there was a huge stockpile of Tamiflu, and obviously now we have to get rid of it. So none of those drugs have been shown to be definitive treatment. They're all still being experimentally used, and different doses and combinations. Additional therapy, steroids, always a controversial one. Again, do we use steroids early? Do we use it later as the patient's deteriorating? Do we use low-dose steroids? Do we use high-dose steroids? And practically every center that I've been reading about is using different doses and different strengths, and earlier or later. Anticoagulants with a low molecular heparin is important. We all know the pathophysiology of the disease process shows a preponderance to micro and macro clotting, And obviously, we need to make sure that that's not doesn't adversely affect the patient. So again, do we use therapeutic doses of Clexane or prophylactic doses? Again, up for discussion and depending on which unit you're working in. Antioxidants such as zinc, vitamin E, and vitamin C are used widely. The latest one, vitamin D deficiency, is coming to the fore. The deficiency stimulates the expression of ACE2 receptor sites in the alveoli. And you can see that if you're vitamin D deficient, you're more likely to have larger numbers of ACE2 receptor sites, and those are the sites that the virus in fact binds to, so could potentially increase the extent or the severity of the infection. Antipyretics, Bufalgan, Panado, those kinds of drugs just for symptomatic relief, and possibly antibiotics if there's superimposed pneumonia. So if that's what we have to do in order to manage these patients, and we all know that once patients get to ICU, the outcomes are generally negative. So how do we decrease the risk of infection? Obviously, social distancing. And I think in our setup at the moment, particularly with the lowering of the levels of the lockdown, on public transport, in our shopping malls, places where there are large numbers of people that are potentially gathering, it's important. Room ventilation is something that's underestimated. If you just open windows in a room, the air exchange rate is much better than any negative pressure or other means that you have to control the ventilation. It is a little bit more difficult now, particularly as we're getting into winter and it's colder. Obviously, as I said, open spaces associated with that, frequent hand hygiene. An important one, which we're not emphasizing enough, is regular surface disinfection. Because fomites are potential sources of infection, or surfaces can remain positive contact areas for up to 4 days. It's important that we regularly disinfect those things. Masks, again, a controversial one, especially fabric ones for the public. Masks in a clinical environment, or for us as medical staff, essential that we realize that the outside of the mask is always potentially contaminated. So touching your mask or fiddling with it and then touching your face and touching your eyes or your nose or your mouth could, even with the mask, potentially spread the infection. And that's been an objection or a concern for people who have been against using masks, to say that you're more likely to spread a greater amount of infection, which is concentrated on the mask. There's no guidelines for wearing gloves, but in terms of your clinical practice and being in an environment where you would be working with patients, essential to use gloves and to change them between patients. Okay, so coming back to resuscitation in COVID patients, so particularly for people working in a hospital environment, all resus procedures must be done in full PPE. That is gowns, gloves, masks, shields, boot covers or shoe covers, and then the proper donning and doffing of that. High risk to frontline staff, things like CPR and BVM use is not advised, simply because they are high risk aerosolizing procedures. You need to assess the likelihood of CPR success. So are there reversible causes? Are there shockable rhythms on a ECG tracing? And that can those be corrected medically rather than ending up with a patient where you need to do CPR. Pre-oxygenation is largely being discouraged, but where it is absolutely necessary in a patient with low set, very low sets, a barrier device. So, for example, any kind of aerosolizing box with a polymask or high-flow nasal cannula. And then what some people are suggesting is to then put a surgical mask over that nasal, the mouth and nose of that patient with the nasal cannula, for example. And then early intubation with a rapid sequence induction protocol is what's recommended. So rather than doing a crash intubation, have some control over the situation and plan it and be able to do it with early preparation. As I said, intubation with a barrier device and a video laryngoscope is advised. And simply because you are now not putting your face over the patient's face, there's a barrier between you. Sorry, alhamdulillah. And a video laryngoscope, which would then increase the distance between yourself and the patient's mouth. So ongoing research in South Africa, as I was saying, there's very little evidence to show any of the medication combinations are working. There's a solidarity trial, which is largely being driven by the World Health Organization, which is comparing standard of care. And standard of care is essentially basically oxygen and symptomatic treatment with antipyretics and things like that, with no additional definitive treatment. And it's comparing that with remdesivir, chloroquine, lopinavir, and ritonavir, with or without interferon, and assessing outcomes of death and the need for ventilation. Another trial that we've been involved with NICD as well is treatment arms comparing standard of care, again with lopinavir, ritonavir, low-dose steroids, chloroquine, and azithromycin. And here the outcomes are death or discharge and ventilation. That's the end of my presentation. I think, I don't know, Zaifa, do you want to do questions now, or do we do the other presentation and then do questions once after that? Jazakallah, thank you, everybody. Huzaifa?
Yes, Prof.
Oh, okay. Jazakallah, that's the end of my presentation.
Sorry, I just disconnected for a short bit.
Okay, no. So I don't know, do you want to do questions now, or do we do the other presentation and then come back?
I think we can do some questions now. There is some time. So if there are any burning questions, if any, I don't see anything in the chat box at the moment. So if anyone wants to, you're welcome to unmute your mic and ask any questions now. We'll leave the floor open for a bit.
Assalamu alaikum, Firoza. It's Shoaib Wadi. How are you?
Okay, Shoaib, and you?
Alhamdulillah. Do we have any evidence or any information about the severity or the potential severity of the virus in HIV positive patients on and off ARVs?
Okay, so we've had, just anecdotally, we've had a few at the Gen positive, and they haven't done badly. Hey, they've come in quite ill. We've had two, one on ARVs, one without, and both of them discharged. But, you know, it's so difficult because we're not seeing the numbers that we initially anticipated. It may still be coming, where we will then have an idea, you know, on what effect HIV is having on COVID infection. We're not sure whether the ARVs, in fact, are going to be protective or not. We're not sure whether patients who are just HIV positive will do worse than those who are on ARVs and those that are not. So there's very little evidence at this stage. I think all of us have been quite aware of the fact that we're worrying about our largely indigent HIV population in the country and how they're going to react to having COVID. For now, we're treating them pretty much as we're doing all the other COVID patients, that there's no real difference in how we're managing them. We're not sure, you know, the fact that they can't mount an immune response and end up with the symptoms that our non-COVID, non-HIV patients are ending up with is very difficult to say. So unfortunately, not too much evidence yet. we're expecting, as everybody keeps saying, to have a bit of a surge towards the end of June. Maybe by then we'll have more patients who are positive.
Okay, thanks for that answer, Doc. Professor. I see Rehana Bayant. Rehana Bayant here's a question. Assalamu alaikum. Besides repurposed drugs, what about convalescent plasma therapy? Is this being investigated in South Africa? And has there been any positive outcomes?
Okay, so convalescent plasma is a big drive at the moment, where they are looking across the world, and there are centers in South Africa looking at it as well. The challenge is, how do we use it? How do we generate it so that it becomes a mass-produced entity that can be, disseminated widely? So there are definitely people looking at it. As far as I know, hasn't been used therapeutically yet, but it has been used in other environments, in other clinical entities. So still, again, one out for the jury, and still, as with vaccines, something that's being worked on quite intensively, but no definitive outcomes yet.
Okay, Dr. A.K. Peer Salams, what is the case fatality ratio?
What is the case fatality ratio?
The case fatality.
Okay, so at the moment to date in South Africa, we've got 14,355 cases and 261 deaths. So if you're looking at that as an outcome, we're looking at it between 1% and 2%. Different centers are having higher or lower fatalities. For example, in South Africa, in Cape Town, there's a higher fatality rate, but that may just be related to the fact that they've got more positive patients at this stage. There are various reasons. Some people are speculating, is it the altitude at sea level that's giving worse outcomes? Is it the higher altitude in Gauteng that's giving better outcomes? But we haven't had all that many patients critically ill in ICU, or the number of deaths. At Charlotte, we've had 2 or 3 deaths to date. So very difficult to say, but across the world, the percentage fatality rate is low compared to the number of patients. And I know, the media and publicity focuses on those number of patients dying. And obviously, one death is one death too many. But if you put it into broader perspective in terms of how many patients have actually been infected, there's 4 million plus worldwide. Then the percentage of the number of people dying is significantly low.
Okay, thanks. The next question that came in, I believe Dr. Fatima Boomkat. Prof. Firoza, on the news there is mention of a rare disease in children linked to the COVID-19. How true is this?
So it is true. They've seen, initially it was thought to be Kawasaki disease, but it's actually, they've separated it to a respiratory syndrome disease that is similar to Kawasaki. So they get the red eyes, they get the rash, they get a red tongue, significantly ill. But, compared to Kawasaki, which is usually in kids under 5, this can occur in older children. The outcomes have been very good. They haven't had a death from one of these children contracting this syndrome. So a newish entity, originally COVID was thought to be child sparing or very low risks of infection or very low significantly symptomatic outcomes. But this is one of the syndromes that is being looked at the moment. So it is in existence, very, very few kids, but obviously, a frightening experience to have a child present like that. So to be aware of it and to be able to get the child to a center that can manage them. But the outcomes have been good with these kids.
Okay, the next question, Prof, from Faiza Bayat. Why are diabetics vulnerable?
So again, remember, any comorbidity, obesity, hypertension, diabetes, all come with their own risks in terms of circulatory damage and inability of patients with peripheral neuropathy, peripheral vasculopathies. And if you're looking at the pathophysiology of what happens in COVID with the microclotting and the thrombosis, thrombotic risk, it puts them at greater risk, particularly for microvascular inflammation and clotting.
Okay. The next question, Prof. Salam, is the December strain in Wuhan more virulent than the present strain? And is the Wuhan strain disappearing?
So, as I said, there's two strains. There's an L phenotype and an H phenotype, and they pretty much have been consistent. There, as far as I know, isn't a different phenotype from the Wuhan one. But remember, as with flu, any kind of viral replication is fraught with mutations and in that replication process. So the chances that the virus is continuously changing is possible, but we haven't really noticed a significant different phenotype from that one.
Okay, a comment from Dr. Shoaib Wadi. It's likely that fatality is lower overall, as many asymptomatic cases may be undiagnosed.
Well, that's true as well. Remember, the asymptomatic patients generally don't end up in hospital. They don't come through. And up to 70% or up to 30%, sorry, may be totally asymptomatic. And if you think about it, they happily going about their daily business. They're not coming into hospital. They're not dying. What is a challenge at the moment in more overseas countries than us and more in the States than in anywhere else is that we're not getting a true reflection of is the fatality or the death of the patient purely COVID, or is it related to, so is the patient dying from an MI and not COVID? Because at the moment, they're pretty much lumping it all together and saying it's all COVID. So, very difficult to say whether, in fact, that mortality rate is accurate or not.
Okay, from Safia Dorat, any comments on the use of UV light in disinfecting surfaces?
Yeah, there's a whole lot of things. There's a little robot that's called a zapper that's using it. UV light has always been used in high risk environments, but obviously then has to be used effectively. Correct frequency, height of above the surface, and length of exposure. So yes, I'm sure it can be, but obviously will have to be in with all the correct recommendations to use it. It's fine to use all the fancy stuff. The bottom line is, if you use a disinfectant, you use hypochlorite solution, you use soap and water, but if you do it properly with all the precautions, it'll have the same effect.
Okay, perfect. From Dr. Ahmed Vachiat, Salam, do you know from in South Africa, has the cardiovascular events increased? Internationally, this has been the trend.
Yeah. So again, Ahmed, I agree. There is a trend. Simply based on pathophysiology, related to the fact that you're going to get coronary artery occlusion, which would lead, and it's affecting younger, almost healthier patients who have no risk for it. So we haven't really had many that have presented to us. All the ones that have come to us have been largely respiratory at this stage. We haven't had a significant coronary event. The other significant group related to the same pathophysiology would be the increase in the number of young strokes. And I know they have seen some in the Cape and in KZN where young people have ended up with strokes. So similar pathophysiology, microvascular occlusion, coronary artery occlusion, or cerebral artery occlusion.
Okay, from Sophia again. Any hope for effective rapid test kits?
Yeah, that's another controversial one. The whole idea is that if you're using a rapid test kit, the vast number of them currently are antibody-based tests. And that means you needed to have been exposed. If you look at the rate at which the virus goes up and the days that it takes, you need to have been infected at least for up to 7 days exposed in order for your body to start manufacturing antibodies and for those tests to be positive. So antibody-mediated PCR rapid tests are fine if you're trying to do screening or surveillance in a large population after the infection to see how much of your population has been has conferred immunity. For our purposes now, we need a rapid PCR test. There is one which is gene expert based, manufactured by Abbott, but Abbott have been forbidden to sell to anyone outside of America at this stage. So if we do have a rapid test, because at the moment the delay in getting test results from our laboratories, and that's both public and private, is about 5 to 7, 8 days to getting positive results. So you can see the implications of that, of having someone who's tested on day 1 and then only gets results on day 7. And in the meantime, that person has been wandering around, potentially spreading his virus. So yes, it would be ideal to have a test, but for now, for testing purposes and to picking up patients who are positive, we need a PCR-based rapid test rather than an antibody-mediated one.
Okay, we'll just be taking about 3 to 4 more questions, so and then we'll be ending the session with another one from Dr. Ahmed Vachat. Should healthcare workers be screened?
So absolutely yes. Because of the number of asymptomatic people, healthcare workers can also be asymptomatic. And if you think of the implications of that, of having a healthcare worker who's positive working in a ward, say an oncology ward, for example, that's huge, or a transplant ward, where the immune compromised patients significantly at risk. So that's the one reason, is that you don't want to spread it amongst colleagues and patients. And I mean, the other implication is, can you imagine having someone who works in for example, a transplant ward, who is asymptomatic but spreading infection, and you end up with the entire ward staff, both doctors and nurses, being booked off for isolation. The other big issue is that we are not isolating enough of our healthcare workers in that environment. So absolutely important. And then the second big reason for doing a baseline screen is, remember, COVID is covered under WCA and COIDA. So you need to have a baseline screen to show that the person was negative and potentially may have picked up an infection at a later stage. So absolutely essential. As far as I know, at Charlotte, we've screened all 4,000 plus employees at this stage as a first line screening. And then I think people in the front line, or people working in high risk areas, COVID wards, ICUs, who are constantly being exposed, need more regular screening as well.
Okay, perfect. Professor, from Dr. Fatima Boomgad, in your opinion, how do you feel about schools opening soon?
Yeah, a controversial one, especially as we all know that little kiddies get sniffles and colds and flus this time of the year. And most parents who would have returned to work are unable to then look after, have environments that they can put these children into to self-isolate. So I think challenges are, how do you socially isolate or distance children? How do you tell a child who's 5 or 6 in grade school, grade 1 or grade 0, don't go hug your friend, or don't touch this and don't touch that? So it's going to be a challenge. I think there's going to have to be screening at the entrance, temperature monitoring, symptom monitoring, And then, possibly innovative ways of running the school, carry on with what you're doing at the moment in terms of homeschooling and online schooling, and then bring children in, for example, if you have a class of 30, maybe bring 15 in this week and 15 in next week. It's going to have to be innovative. The one plus is that kids have been largely asymptomatic or very mild illness, which would help to confer some kind of herd immunity into communities, because kids would be infected. The one big risk with that is, particularly if a child is living with an elderly grandparent or a grandparent or an older person who has some kind of comorbidity or illness, and the child then taking that home and spreading that infection to that person. So huge numbers of challenges. And I think that that's what they're grappling with at the moment, and which is probably why schools haven't been opened sooner than now. Okay,
thanks, Prof. From Dr. A.K. Peer, please comment on hypercoagulation in COVID patients.
Okay, so I'm not going to go into the whole pathophysiology, but there is definitely a trend for coagulability or clotting in patients, and that's what's causing both the microvascular and macrovascular symptoms. The first patient that died in Cape Town was a pulmonary embolus. So you can see how, she had COVID, but no other risk factors for PE, and died from the massive PE. So there's definitely a risk, and that is why we're using Clexane prophylactically on all these patients in varying doses. The other extreme is that patients also end up with a DIC. So it's a whole spectrum of clinical vascular pathology that's occurring.
Okay, thanks for that, Prof. From Dr. Desai, I believe Dr. Desai joined a little bit late. He just wanted to know about the convalescent plasma therapy.
Okay, so as I said before, something that's being investigated, because obviously if you think about it, patients who have immunity to that strain of the virus that they were infected with, and they produced antibodies. So how do we harvest those antibodies? How do we multiply it? How do we get it into a form that is not going to be, stimulate somebody else's immune system, almost as like a transplant kind of setup? So it's being looked at, it's being worked on across the world. There are huge numbers of sites working on it, equally huge numbers of sites working on vaccine production. But both of these need to be significantly tested and investigated before they will be ready for any kind of widespread distribution and use.
Okay, Doc, the last question. I see there's two more questions, and then we will end the Dr. Talat and Dr. Saluji. Otherwise, we will run too late. Maybe at the end of Dr. Zair Essop session, if there is time, we'll do the more questions. Right. So we'll just take this last two now. From Dr. Talat, should asymptomatic contacts with positive PCR result be isolated from 14 days of the last contact or 14 days from the date of the positive test?
Okay, so if you have a patient, if you have a person who's very sure of when they came into contact with someone, you can take it from there. There are very few people who can do that, however. So we at the moment are using date of test. So example, if you came into contact with someone, you've done very little traveling, very little outside work, you went to a meeting or to a shop or to wherever on a particular day, and you can pinpoint it to that day, then that's the 14 days. However, the vast majority of people can't. So we're taking it as of the day from test. The other reason we're doing that is that there's varying ranges of 7 to 14 days of an incubation period, and even going down to 1 or 2 days of an incubation period. So because of that huge gap, in the range of the incubation period, it's very difficult to pinpoint exactly when that day was. So for the vast majority of patients at this stage, we're taking it as the day of the test.
Okay, lovely. And with regards to the last question from Dr. Fatima Siluji, Salams, Prof, we are now in lockdown. What are your thoughts about lifting lockdown and the population developing natural immunity?
Okay, so it comes back down to the whole herd immunity thing. The lockdown wasn't meant to prevent the infections. The lockdown is in most places was simply meant to give the health system largely a chance to prepare and plan. And that's the reason. So as they're lifting the stages of lockdown, it is to then increase the number of infections, but in a controlled manner. So yes, the lockdown helps in terms, it looks like it's slowing down the infection, but the minute you start lifting it, you are spreading. And that to a large extent is what you want. You want a large number of the people in the population to be infected and to be hopefully asymptomatic, but develop immunity, which then results in a big degree of herd immunity. Because for as long as you don't have that herd immunity, you're constantly going to get waves of new infection. That's not having to say that the virus won't mutate like the flu virus and have a different strain every year, which may mean that you need to have a vaccine every year developed for that strain of the COVID. So definitely larger numbers of people, larger number of children, particularly to be infected, to extend that herd immunity.
Okay, thank you so much, Doc. I see a last question has come from Dr. Chauhan. What is the rate of the false positives? And then that's the last question, everyone.
All right.
From the last question, yeah.
So at the moment, across the board, we're looking at up to 30% of a false positive or false negative. So currently in South Africa, because we're no longer using proper viral transport medium, we're using dry swab testing. There's a huge risk. And I mean, we screened, as I said, we screened all the staff at the hospital, and a significant number of them came back as indeterminate. And that's simply because of the way we're testing. So those people had to be retested. So there is a risk. And we've had instances where a patient was tested, for example, at one private laboratory, came back positive, and then tested for some reason the doctor didn't believe that the patient was positive, tested at another laboratory and came back negative. So a third test had to be done then to make sure that the patient was positive or negative. So there are instances where there is a false positive rate. At the moment, the quoted figure is about 30%, but that varies across the board.
Lovely. Thank you so much for that, Professor. It was lovely having you. Prof, are you going to be available till the end of the session?
Yeah, I'll stay in.
Okay, so if there are any other further questions at the end of Dr. Zahir Essop's session, we will avail it for Doctor.
Okay.
First, Professor, thank you so much for making the time. It was a really interesting discussion. I think a lot of us have learned many new things, and I think it's an important conversation that we need to be having now, and especially with the myths, the facts, and a lot that is going around and is available in the media. I think that it's important that we get the proper knowledge from people like yourself who have so much experience in this field. Thank you for that, Professor.
It's a pleasure.
Okay, we will be having just a quick 2-minute break while Dr. Zahir Essop is busy setting up. Dr. Zahir Essop will be coming on, and Dr. Zahir Essop will be leading the next session. So there'll be just a quick 2-minute break, and thereafter Dr. Zahir Essop will be on with the next session.
Association of South
Sound check. Bismillah ar-Rahman ar-Rahim. Can you hear me?
Yes.
All right. Bismillah ar-Rahman ar-Rahim. Wassalatu wassalamu ala Rasulillah. I'd like to thank the Joburg IMA for putting me on the spot as usual in our first Webima. Interesting, when Feroza started talking about the small children at school with masks, I was just thinking the line of children sharing masks and the line of parents trying to figure out which part of the child, which child lost their mask and which child lost their socks, and probably not being able to tell the difference. Anyway, a little bit about myself before we start. Unfortunately, my CV is not as comprehensive as Dr. Feroza's. I'm a student of medical fiqh with Al-Balagh Academy in the UK. I'm actually an anaesthetist by profession. Did my undergraduate and postgraduate at the University of Pretoria, and I'm also a Hafiz al-Quran from Maulana Abdul Samad Dayasab. I think we can get straight into it. So today's talk was a primer on Islamic bioethics, and it sounds quite a big deal and quite a comprehensive issue. But the problem is that as soon as you put a title like this, then everybody goes, ethics, and we're just here for the CPD points. So inshallah, we're not here only just for the CPD points. We learn a little bit, but most importantly, I think I'm just a learner in this field, and there are probably many of you on this group that know a lot more about ethics, about Islamic ethics, and about medical fiqh. So from my side, what I'm not is I'm not an alim, I'm not a bioethicist, and I'm basically just a student of fiqh. But alhamdulillah, through the last 6 months or so, I've learned quite a bit through Al-Balagh about the basics of the fiqh of medicine. There's a brief outline of our talk today. So we're going to define the terms used in Islamic medical fiqh and bioethics to highlight the similarities and differences between Western and Islamic bioethics, the scope of medical fiqh, issues affecting clinical practice, and then some specific current COVID issues. So the talk is aimed at health professionals, Muslim, non-Muslim, does not matter, but who are day-to-day interacting with Muslim patients to give a bit of context to that consultation. The patient comes to you and they're fasting and they say, no, you cannot look down their throat. Or patient comes to you and they're fasting and they cannot take oral medication, so they ask you for an IV medication. Things like that, basics through a consultation. In fact, later on in the talk, we go through a basic consultation where Islamic bioethics comes into play in almost every aspect of your conversation. And then health professionals seeking to further the knowledge on how legal rulings, fatwa, are derived. Because oftentimes we get the fatwa and we reactively try and adapt our medical practice to adapt to the fatwa without understanding the context of where it comes from. And like most things in life, fatwa are based on context. And then to stimulate areas around these areas of bioethics and to actually come up with a context-specific, especially our African context, a context-specific, cultural-specific way of dealing with Islamic bioethics. What this talk is not, it's not a comprehensive review of Islamic bioethics. It's not the see one, do one, teach one guide. No, for instance, like myself, and none of this here is prescriptive because I haven't done a short course and now I can teach you this course and tomorrow you go and make fatwa. That is not this. It's aimed at this course and at enhancing good questions so that later on we can come up with proper fatwa, proper guidelines that are well informed. So let's first go through some of the terms used in Islamic bioethics and in fiqh. So ethics is then, as we all know, a sub-branch of applied philosophy is usually linked to morality, but not always. It tries to differentiate between the right and wrong and the good and the bad. And McNair in the medical ethics in the BMJ, he's got a very good description of medical ethics, which is now ethics taken to another level, or a sub-branch of ethics. And it's an analytical activity in which concepts, assumptions, beliefs, attitudes, emotions, reasons, arguments underlying the medical, legal, moral decisions we make are examined critically. So Islamic medical ethics, now we've seen the ethics, we've seen medical ethics. So I mean, surely you can just add Islam onto there and make it Islamic medical ethics. But herein lies the difficulty, because in ethics, in Arabic, there is no real word for ethics. And ethics, like with normal ethics and medical ethics, Islamic bioethics has a major overlap between the major portions of the fiqh, which is now your judicial rulings or jurisprudence, kalam, and then tafsir of the Quran. And these three, it's sort of somewhere in the middle. If you were to draw a Venn diagram, then we're sitting somewhere in the middle. And there's no exact word for ethics in Arabic, like I said, but it comes from akhlaq and adab. So the akhlaq literature and the adab literature, akhlaq is khalaq, it means to create. And from the adab literature, there's a lot of work on biomedical ethics. So I think the most famous one for us is the 9th century Isaac bin Ali al-Ruhawi, the Adab al-Tabib, where it's used comprehensively throughout the world as a basis for Islamic bioethics, and in fact for Islamic ethics in general, with some interesting chapter definitions that go towards the character of the clinician as much as the way the clinician interacts with patients. When it comes to Islamic fiqh and jurisprudence, we often think the ulama sit and they've got this big encyclopedia which they go through, or they sit and deliberate in a big gathering and then decide what how fatwa comes from. I'm gonna just switch from now. Apparently there's a problem with the sound. I hope that's better, inshallah. Okay, so when it comes to Islamic fiqh and jurisprudence, the ulama have a number of different sources in how they become, how they come up with legal rulings of fatwa. And the first two sources are the primary sources, is the Quran and the Sunnah. And in a lot of cases, the Quran and the Sunnah explicitly decide what the fatwa are going to be. But there are many instances, for example, organ transplantation, where there is no mention of whether you can receive or give organs, or whether you should be giving or not receiving transplants. And in that case, the Quran and the Sunnah, there's no direct mention of that. And that's where ijma' comes in, where the ulama get together, they have a look at the primary sources, they look at what is inferred, what is referred from it, and come to a decision. And many of the organ transplant decisions we've taken from international conferences are based on ijma', especially in the Arab world. The fourth way they come up with fatwa is something called qiyas, analogy. So if an example is given of some instance where a certain ruling came out, they infer from that another ruling. And one of the other ones, there are a few other ones that are not as strong as your primary sources, and one of them is urf, custom, taking into account the local population and the local practices. So I'm not an alim, we've been to this Islamic bioethics, and what's the point? What does it matter? Why does it matter? We're not going to be doing rulings, why should we know? And I put it to you, the biggest issue when it comes to fatwa, especially in the South African context, is that we're getting a legal ruling. The ulama are going through all their sources, but the input, the question asked, is not as good as it should be. So the quality of the question asked is just has a major impact on then what fatwa we come up with. So as healthcare professionals, if we've got insight into what Islamic bioethics, into our basic medical knowledge, into our speaking to our experts in the field, and to ask the question in the context of knowing how the ulama are coming to come with a ruling, the quality of our fatwa, the applicability of our fatwa, and the drawing up of guidelines is going to be so much easier. So the second section of this talk is going to highlight some of the similarities and differences between Western and Islamic bioethics. So we've all studied the principles of biomedical ethics, 1985 or so, from Bosham,
where they've taught us about respect for autonomy, for beneficence, for non-maleficence, and for justice. And a lot of these are very patient-centric and go towards the principle of first doing no harm. And interestingly, the Islamic bioethics enhances these four principles that we see here. So our Islamic bioethics is based on the 5 maqasid al-sharia, which means the 5 objectives of Islamic law. So any law that comes out or that is derived, or any fatwa that is derived, should be able to encompass these 5 beliefs. The one is the maintenance of life, the protection of freedom of belief or freedom of religion, the maintenance of intellect. You think of your stroke patients, of your patients who are in a persistent vegetative state, all of these rulings can come from that. The preservation of honor and progeny, and then the protection of property. And protection of property is interesting because should we go for the no cost spared or all costs for one patient, it comes towards your dealing with allocation of resources as such. We're going to go towards the scope of medical fiqh now to try and get to the meat of the talk. There is just the basic boring part. Now we get to the interesting part where there's more questions asked and more questions raised than answers given. So here's some of the examples of the scope of medical ethics, and I'm sure many of us have read a lot of documents and opinion pieces of seen patients who've asked us questions, and it's sort of a gray area, or we normally say darura, necessity, and we don't really understand the basis of this. So when it comes to obstetrics, TOPs, it's legal to do TOPs. Is it medically indicated? What's the indication for it? How long, during what trimester can we do it? Should we do it? Should we go for the mother? Should we go for the child? What should we do? And then when it comes to fertility medicine, so I mean, patients are having children later and later because of their professional careers and the rise in infertility. So the patient wants to undertake fertility treatment. Should they have the same sperm, same donor? Can they do surrogacy? Can they donate sperm? The mechanics of harvesting, should they terminate, should they select some of the ova? These are all issues which the Islamic bioethicists deal with on a day-to-day basis. And then another big topic is organ transplantation. So I mean, there's multiple Islamic conferences over many decades that have had these discussions and have come up with various rulings. By far and wide, the consensus by the majority of the ulama is that you can donate solid organs, you can receive solid organs, you can receive blood and blood products. Living donors, in fact, are encouraged because we know وَمَنْ أَحْيَاهَا فَكَأَنَّمَا أَحْيَا النَّاسَ جَمِيعًا, and we always use it in our medical context. But if you save a life, then it's like you've saved the whole of mankind. And so giving somebody a kidney, is that not the ultimate gift for trying to save somebody's life? In the UK, they've got now an opt-out philosophy or opt-out policy. So across the board, all the citizens are now by default organ donors, and you got to opt out. And there's been quite a bit of work done about that by the British Islamic Medical Association and by Al-Balagh and various other organizations in the UK. What about end-of-life decisions? When do you withdraw treatment? You know, it's often difficult when it's your parent and you're at a no-cost spared issue where you want to spend as much as possible and get them the best treatment with the best doctor. To what point? When it comes to artificial nutrition and hydration, all of us have had that call where they say, doc, just come home, put up a drip for Ma, she's not feeling well, you know, she's at the end stage. Should you put up a drip? That Ringer's lactate lasts for half an hour. What should you do? What is the moral, what is the ethical thing? What are your ethical considerations and your moral considerations from an Islamic point of view? What about do not resuscitate orders, especially in the COVID system, where you've got a patient, you know the CPR figures are dismal, but this patient was otherwise a previously healthy patient. Should you go there? Should you put, the patient said, do not resuscitate me, and the family comes and says, you know, Ma said we mustn't do anything, we must let her go, but you know, who has, so these are all, from an Islamic bioethics view, need to be taken in context with the local requirements of the legal requirements of your country as such. What about euthanasia? Many countries are legalizing euthanasia. So we need to think about, patient comes to you, they request euthanasia. Like TOP, are you then medically obliged, are you morally obliged to refer that patient on to somebody who does practice it? Or can you say, this is my moral stance and that's it? And then the concept of certainty. So, I mean, some of them are quite obvious that, listen, you cannot resuscitate. But what about a patient who says, listen, oh, in simple terms with COVID, The figures for CPR is dismal. What's dismal? I mean, what concept of certainty? So that's sort of a gray area. Is it 20%? Is it 50%? The doctor says I'm going to die in a year's time. Is it 50%? Is it 25%? And at what level of certainty can the ulama rule that this is allowed or not? Something which we don't touch on, pardon the funny picture they got there, I don't know how it got there, but as far as mental health is concerned, traditionally in our culture, in our religion, depression, schizophrenia, and other issues of mental health have been looked in is not just a biological illness or an organic illness, but there was always a bit of a spiritual side to it. What about jinn? What about sihr? No, people know it's a jinn. Person starts developing schizophrenia. No, I'm sure it's a jinn. And at the back of their mind, it's more to go for to consult somebody for jinn before we start thinking of mental health. So there's a lot of work to be done in all faculties, in all disciplines across our profession. What about the fiqh of fasting? So Muslim patients with chronic conditions. So, for example, a patient, obviously, what Firoza mentioned, where a diabetic patient with all of these other comorbids, and the uncle can't fast. What about a patient who's got peptic ulcer disease or Crohn's, or needs a PD dosing of, let's say, the inhaler, and they've got a 16-hour fast? Sort of a gray area, because in functional status, the patient is still okay. So they feel they should be able to fast. And yet, from the medical profession, we're saying no. And these are essentially based on three things. The one is the ulama rulings. The one is personal experience. The patient knows if I get a migraine, I'm going to be throwing up, I'm going to be really, really suffering, I'm going to get dehydrated, and so I have to break my fast and take qada. Or then medical advice, where we should know, listen, even if it's a chronic stable condition, but the medical dosing may lead to further harm down the line. So this is sort of the scope of medical ethics. It's vast. It covers all the aspects of clinical practice, and I think a lot of work needs to be done in these areas, and there's a lot of potential for work in these areas. Very interesting when it comes to Ramadan and fasting. Many of you know the International Diabetes Federation, and they've got an amazing guideline. They've got a few multi-center, multi-country trials, and they've got a beautiful series on Ramadan and diabetes, how to approach them, how to bridge your patients. It's a beautiful resource in terms of let's say they're on insulin, on oral hypoglycemics and that type of thing. It's really an amazing resource, and I urge you all to go to this website. So then the next sort of section of our talk is just about the issues of clinical practice, and we'll just go through a typical consultation and where some of the issues come in. So the important thing with the consultation is khalwa. I mean, we were told you are mahram, non-mahram, you can't be secluded in one room together, and yet you're sitting now with this non-mahram woman here, and you're having this conversation, and you're a man, and there's nobody there. Kind of like, and we've always at medical school, they always talked about chaperoning, which is not always practically possible, especially in resource poor areas. So I think the rule with this is that the medical needs must justify the interview, the consultation. And simple thing like, so how these things, the fuqaha and the ethicists come to these decisions is that the hardship will dictate the necessity. So if there is no female doctor available, then you're a female, go for a male doctor. But if that person is not competent enough, or that person is not, let's say you need to see a specialist, the only intensivist around in your area, or the only pediatric cardiologist in your area, and the next one is probably a few hundred kilometers away, then there's a significant amount of hardship that will dictate the necessity for you to see a non-mahram doctor. When it comes to examining patients, then we look at exposing the aura. We all know the aura. There's for men, it's from navel to knees, depending on who you follow. And from the ladies, it's usually sort of from including or excluding the hair, but from the shoulders to the ankles. So once again, hardship should dictate what we actually can do. So if it's possible at all, without exposing the patient's aura, to make a diagnosis, an accurate diagnosis. So we don't have to try and make an inaccurate diagnosis, because it's negligent by not exposing the aura. So necessity should dictate what we should do. What about unconscious patients? Unconscious patients in your ICU, unconscious patients you find on the street. How much you need to resuscitate that patient? Do you rip all the patient's clothes off before you start CPR? What should you do? All right, so the hardship should dictate the necessity. If you're unable to do good chest compressions because the patient has got on a scarf or a hijab, or a thick jersey, then you're going to have to expose it. But if you don't need to, you don't have to. What about theater? Oftentimes they're preparing a patient for theater, and while the sister is still counting her instruments there, patient lies totally exposed. So these are some of the considerations when it comes to aura. And then now you've seen the patient, you've examined the patient, and now you need to give a prescription. So what prescription do you give? Some, for example, Clexane. A lot of people say Clexane has got porcine ingredients, or is used in the porcine ingredients are used in the manufacture of it. Are there alternatives? How can I give me? What about vaccines? We've talked about certainty. So there might be haram ingredients in the vaccine, and there's not a certainty that if you don't take the vaccine, you won't get, let's say, the flu. So when will it become permissible? And here, once again, there's a lot of work that needs to be done. And I think the important thing from a South African context is we need to get involved with the ulama in coming out with proper guidelines, ask the right questions, and come out with the right papers to be able to give them tools to come up with the right fatwa. Some of the resources when it comes to halal medication, Hasana has got a helpline where many of our halal certification bodies do have helplines where you can find out if, especially over-the-counter medications, whether they're halal or not. There's halal drug lists. I know IMASA is redoing some of the publications where there was an old publication, a very, very comprehensive drug list done a few years ago with all the halal and haram drugs on the market and alternatives. It is a very, very useful document, but obviously it's been outdated. And I know IMASA, some of the guys working with IMASA are trying to redo the publication and update the list. So I think now we come to the most controversial part of the whole talk, and it's about COVID-specific issues. A lot of questions have been arisen about some of these issues, and there hasn't been a lot of shall we say, not the proper questions have been asked, and we haven't got we've got many differing fatwas and many differences of opinion when it came to the fatwa. I think I want to start first by saying about this information pandemic we're seeing. It's unbelievable the amount of fake news, news that sort of pseudo-right as received, forwarded as received. I'm just forwarding, putting it on a group, especially on the WhatsApp, and a lot of times quoting people with dubious reputations. I just want to quote this hadith. Nabi said, Abu Hurairah said that the Prophet said it's enough for a man to prove himself a liar when he goes on narrating whatever he hears. So if you put something onto a WhatsApp, you need to own that post. Be able to justify it, have a look at it. Don't post it and say, is this true? Do your own research. In many other aspects of life, we don't tell somebody, where is butter cheaper? We go and look for it. Do your own research and then bring it to us as information that's been verified. I think that'll help a lot, especially when it comes to the many different messages we're getting. What about resource allocation? Firoza mentioned the whole scramble for ventilators, or when the vaccine comes, who gets it? Is it the first come, first serve? Is it the number one citizen in the country? Is the man on the street? Do we exclude old people? Do we exclude young people? What about a person with the best social standing, the most pious? The ulama get it first. The professionals get it first. They're more productive in society. So all these things need to be thought about, questions need to be asked, and a lot of work needs to be done in these areas. And I mean, a lot of the answers lie again then in the maqasid al-sharia. These are the 5 sort of objectives of any Islamic law. And I think when we ask the questions to the ulama, we should keep this in mind also, that we get a proper fatwa coming out. What about COVID-19 testing? Pardon the spelling mistake there. Will it invalidate my fast? What if I do it oropharyngeal? Do I do it nasopharyngeal? I mean, you know, that's one of these considerations. Can I refuse a test from Islamic bioethics point of view? It's for the greater good. Am I able to, can I refuse a test, or must I then obviously do whatever the government tells me to do? What about PPE? You know, we work in theater. It takes a very long time to put on PPE. It takes a long time to take it off. And you need to read Salah. Winter is coming. The Salah times are very, very short. Can I read Salah in my PPE? Can I make tayammum if I can't get my gown off? What about, as many have noticed, my beard is a few centimeters shorter than it usually is. Must I shave my beard if I can't get a proper leak test with an N95 mask and I'm working in a high-risk environment? These questions from an Islamic point of view, not from and then obviously from a lot of these, the British guys, because they are a few weeks ahead of us in the pandemic, have done a lot of work with. And I think there's some good reading between the British Islamic Medical Association, Al-Balagh, and other sources. What about isolation and quarantine? Can I refuse from a Sharia stance The government can't tell me I should be isolating. You're not supposed to be a hermit because a lot of my worship is done congregationally, that type of thing. And once again, it comes back to the same thing again, the maqasid al-sharia. So everything we do needs to keep this in mind. All right. So anecdotally from the British guys and from our local guys, there's been an unprecedented interaction between our ulama and our medical professionals. So we need to be able to ask right questions to them, not just ask questions and not just expect opinions from them and let them produce the information, but we should be able to do a lot of the groundwork for them. Give them proper anatomy, give them proper physiology, give them medically sound, medically based advice so that when they come out with the legal rulings, it can be universally used, it can be effective, and it can be justified in whatever part of society we interact in. And then in terms of from our side, we need to also know what level of certainty do we need before we advise ulama for an action, especially in COVID time. And I think Feroza's talk has got a long way to allaying a lot of the fears, dispelling a lot of the myths, and giving us a lot of food for thought in where we can direct this so that we can give appropriate advice. I mean, we've all been involved pretty much on many levels in massage guidelines. So who gets to advise these committees? I mean, does WHO, the World Health Organization, do it? Does the most pious in communication in society do it? Do public health experts do it? Does the government just dictate and that's it? What happens if the government dictates and I quietly go to the masjid? Is it from an Islamic point of view? Is it wrong? What about health professionals who are ulama because they've got the best of both worlds? What about Muslim legal professionals because they understand the laws of the land and the upstanding Muslim citizens? So it's still a very a gray area, and I think the answer lies in the collaboration between all of them. So that's the end of my talk. I thank you for listening. I thank you for not eating during the conversation. We'll take questions from that's okay.
Okay, Jazakallah to Dr. Yusuf. Jazakallah, Doc. That was a lovely and insightful talk. I think many people benefited. Islamic bioethics is not something that we often cover, and most of us don't get it in our undergraduate studies. So it's actually quite interesting to see, the relationship between Islamic and Western ethics, and we really appreciate that. Doc, you started before I could actually give an introduction. So just a quick introduction to Dr. Zaid Essel. Doctor qualified in 2002 from the University of Pretoria with his medical degree, and he also done his postgraduate anesthetic training at the same university between 2006 to 2010, and doctor practices in private practice currently. Doctor is also a Hafiz. He completed under Mulana Daya in Benoni in 1992, and he has also completed a pre-alim course. And Doc has also recently completed a level 1 fiqh of medicine course through the Al-Balagh Academy in the UK. I see Professor Mutara has her hand up. Prof, is there something you would like to add on or question?
Jazakallah Zair, that was an excellent talk and put it in perspective for many of us. A lot of the issues you raised are things that particularly undergrad Muslim medical students are coming to us with and saying, give us guidance on. So thank you very much for a very informative talk. There's just two comments I want to make in terms of posting or forwarding information that we're receiving. By forwarding information, you are as liable for it as the first person that sent it out. And according to the POPI Act in South Africa, currently you can be prosecuted or arrested for it. And a way to sort of avoid forwarding non-factual information would be to actually go onto one of the fact check websites. There are people who are sitting constantly checking whatever's being sent out there. And then the other thing was with regards to refusing a test. I think in most countries, the public health benefit, as you said, the benefit for the greater good overrides sometimes an individual refusal. And also to remember that the law of the country that you live in, and I think even Islamically that says that you obey the law of the country that you live in. So if the law says you have to take a test, for example, then unfortunately there's very little left in terms of my refusing, because that does put you or does make you open for litigation and arrest potentially. Thanks.
Yeah, it's excellent. Jazakallah. Thanks, Firoza. I think one of the good websites to use is Africa Check. I find them quite useful, especially with our South African issues.
Gee, I agree.
Prof, while you're online, I see there was a question that came earlier from Dr. Fatima Boomgad with regards to, with the answer that from Dr. Zubair Chan's question, what is the rate of false positives for COVID tests? She wanted to confirm, was that false positive or false negative tests?
So very difficult to say. The false positives that we're getting are up to 30%. The false negatives, we're not sure, but there is a significant number of them as well, because we've had to retest people. I think it's largely to do with the type of test that we're doing rather than the actual process.
Okay, thanks. Dr. Zahir Asab, there is a question from Dr. Desai. What about sterilization? Does wudu break when examining a female patient after checking aura rules?
So, Dr. Desai, sorry, but as I mentioned at the start of my talk, I'm not an alim. So I think the best thing is to consult your local alim with the right questions. Explain to him what sterilization is and does wudu break, depending on the patient, whether which madhab or whether the patient follows a madhab and which is the majority rulings. As far as fiqh rulings concerned, I don't think I'm qualified to answer these questions.
Just from my side, I think if there are any fiqh questions that are posted, we do have groups within the IMA that are dealing with some of the fiqh rulings. So I think we can record these questions, and then when we send out some of the feedback from this session, we can send the replies to those questions.
So how do we spell that question?
Dr. Zahir Asab, from my side, with regards to the Islamic medical ethics and just some of the courses that you've done recently, with regards of the fiqh of medicine, how important do you feel that it is for us as Muslim professionals to get some Muslim health professionals to get some insight into the fiqh of medicine?
No, I think it should be compulsory undergraduate study for any Muslim health professional, not even doctor, but any Muslim health professional. It really offers insight into a lot of aspects which we take for granted. A lot of questions we ask the ulama, we don't understand why they come up with these questions. I'll give you a simple example. When it comes to fasting, we've got this thing, you can't, your fast breaks if you swallow water or medication goes down the nose or down the mouth or per rectum. But we've got nothing about, but the eyes, why not the eyes? The eyes, you've got a lacrimal duct that goes to your torus tubarius, into the nose. So why don't we do it with the eyes? And it's amazing because it's just basic anatomy. And when you go through the course and they give you the rationale behind it, the Islamic basis for it, the Sunnah basis for it, it just makes sense. So I think it should be essential reading for everybody. And especially in all those aspects of medicine, I think it's crucial. And there are quite a few good courses out there. But unfortunately, locally, we don't have a very well-developed course yet. Inshallah, IMASA will get one at some point. But Al-Balagh, I find, was very well balanced. The teaching was excellent. And there was a strong emphasis on the clinical aspect of it and very, very well researched.
Jazakallah for that, for Dr. Zahir Asab. I do think that the Islamic Medical Association is looking at doing these type of sessions and lessons, maybe not full courses, but there might be specific sessions and lessons where these will be covered. And I think it will be important. So if we get feedback from this, we know whether online is the way to go, whether we should have virtual classes, or whether people want reading material and things like that. So it would be important to get feedback from the session, especially that this is the first Islamic Medical Association webinar session that we've had. I see in the comments from Dr. Zubair Chauhan, for Dr. Desai, with regards to the vasectomy, I have received a written fatwa from Camperdown Fatwa Department that it is not allowed if not for medical reasons. So I think for those that are interested to contact Dr. Zubair Chauhan, who would be able to give the written one, or to contact the fatwa departments directly so that they can receive the fatwa also.
Anyway, Jazakallah, Hafiz Huzaifa, for inviting me. I just like to say that we just like to commend the Islamic Medical Association for having the first one, hopefully with CPD accreditation, and hopefully we can go forward and have a whole series of talks. So just based on the attendees of this talk, I can see quite a bit of speakers here. Put your names up, put your hands up. Those of you who are not members of IMASA, we actually need you in IMASA. We are really looking at the wealth of information and the wealth of talent amongst the Muslim health professionals in South Africa. So please, if you guys get a chance, contact Sister Kashifa, even contact on the chat now, I suppose. Become members, start contributing. There's been so many questions raised in these two sessions that I think a lot of good work can come out of this, inshallah.
From Dr. Chan, also a comment, just a comment. I think that we should involve our ulama more and more in today's times, especially when it comes to fiqh rulings. Perhaps have a dedicated ulama group liaising with Islamic Medical Association and the ulama. I think that's very important, and it is something that we are looking at. And I think that importantly in future sessions, we will also cater for that way we can have ulama on our sessions also to answer these questions specifically and to talk about it from a fiqh perspective, as Dr. Zaid Esop mentioned earlier on, that it is about the context and the proper presentation of the questions, the quality of the questions. So it would be important that we need to give them the correct quality of questions, and then they'll be able to give us correct answers. From Dr. Abdul Desai, I think this is for Dr. Zahir Esop. In a recent talk, alcohol-based sanitizers passes through the fetus. Your opinion, please.
Dr. Desai, so there's lots of things that pass to the fetus that are sort of halal or haram or whatever the case is. Once again, it's sort of a fiqh-based question, which I'm not an expert to decide on. But I'd like to add on to that. So besides alcohol-based sanitizers, what about these chlorine or alcohol-based sanitizing tunnels? So all of these questions are very important questions. And I think we should start approaching our ulama about this. In terms of the interaction between IMASA and the ulama, I don't know, many of you might not know, but in Gauteng, we've actually had already an ulama health professional sort of little conference, and there are various interactions between the IMASA and the local doctors in Joburg and the Jamiat al-Ulama, where they are trying to start, like they have specialist departments of fiqh in, besides just general Islamic law, in financial law, they are starting now health fatwa department or medical fatwa department, and we've been having a lot of input in that. So these type of questions should be directed at your local ulama, at your iftar department, preferably of your local ulama, and or then directed to one of us, where we can then forward this onto the onto the group, and the ulama will base this, and they normally give us proofs with this, inshallah.
I see in the comments Dr. Shoaib Wadi has mentioned that we do have a WhatsApp group currently with ulama to which specific fiqh questions are put. So I think that's also an important step that the Islamic Medical Association has taken. So any questions can be forwarded and to the relevant members, Dr. Shoaib Wadi, Auntie Kashifa, Dr. Zahir Esop. And we can forward this, and also those who would like to be maybe part of the group can forward their names and numbers, and we can look at adding others to the group. Are there any other questions for Dr. Zahir Esop or Professor Firoza? Okay, if I see Prof has her hand up, Professor Mutara.
Just a last comment. Jazakallah so much for inviting me. As he says, I think this is an excellent initiative, and I agree with you. There are huge numbers of people on this group, from the names that I can see, that potentially have a huge amount of knowledge and information to share. So well done, Kashifa and Huzaifa, for the organization.
Thank you for that, Prof. And thank you to yourself and Dr. Zahir Esop for making the time and availing yourselves on a short notice. This wasn't planned too long ago, and on short notice for making yourselves available. Also to the attendees for making yourselves available on a Sunday. We will be sending out a survey shortly, so if there are any comments, anything that you want to add on, whether this is a good time, whether a different time would be better, whether this platform worked well enough, and anything, maybe future topics that you would like, as mentioned by both Prof and Dr. Esop, that there are a lot of speakers that are available here, and if you would like to, if you feel that you have something, not if you feel, but I'm sure most of you have something to contribute to the different discussions that are going around in your field of speciality, you are welcome to contact Kashifa or any one of the Islamic Medical Association members, so that for the future webinars we are able to plan ahead of time and have you schedule for the different webinars. So thank you to one and all for joining. Importantly, one of the things that does come up in these sessions is with regards to the Islamic Medical Association. So the Islamic Medical Association, at times there are misconceptions about what the Islamic Medical Association does and whether they're just a relief organization or just providing screening in underprivileged areas. But the Islamic Medical Association is a broad organization. So apart from relief work, doing screenings in underprivileged communities, having clinics in underprivileged communities, the Islamic Medical Association has various opportunities available for people to volunteer, give their time, do some work in, and we invite one and all to participate and become members of the Islamic Medical Association. It's very easy on the Islamic Medical Association to sign up directly via the Islamic Medical Association website, and we will also send out a website link where people can sign up via. So it's important that that people sign up. You might have seen that there's also a price difference in the membership fee compared to if you're not a member. So you'll also be able to get a small discount. So we would also like to request that once the survey is sent out, for people to respond to the survey. From my side, I would like to thank one and all for being part of this first webinar, and I hope that you all enjoy the rest of the day and the rest of the Ramadan, and keep the Islamic Medical Association in your du'as. Assalamu alaikum.
You should have put your hand up.
Huzaifa?
Yes.
Are people still on? We can just maybe mention, Dr. Ashraf Jadar wanted me to mention that there's also FEMA has got an encyclopedia of Islamic bioethics, which also has got quite detailed information. And there are lots of publications done by the IMA, obviously, over the years, on which have collated some of the fatwa which have been presented over the years to us.
Okay, perfect. Yes, I think there are still quite a number of members online who would have heard that message. Yeah. Okay, Jazakallah for that, Dr. Shia.
Okay, good. Done.
Okay, so that's the end of the session. Jazakallah khair, and thanks to everyone for joining us. Assalamu alaikum.
Connect to Muslim health professionals in South Africa and the world by joining the Islamic Medical Association of South Africa and play a role in improving the health of the disadvantaged communities.
By becoming a member, you join an organization that gives you an opportunity to meet and network with fellow Muslim health professionals.
Contact Kashifa at 011-837-6717 or visit ima-sa.co.za.
The Islamic Medical Association, IMA, caring for our community.
Assalamu alaikum.
Assalamualaikum.
You kept on disappearing, bruh.
Yeah, Kashifa had some electricity issues.
Today, out of all days, they decide they're going to go on with us. Seriously.
Shame, man.
I'm going to go to Zaifa's house next time. I won't do it from my house. It's fine. It's stressful.
No.
No, it's stressful. Seriously.
But what was the problem? Is it just your network?
No, you know, here at the back, there's Slover at the back. So they're stealing the cables there. So for the past 2 months, is there other
There are
sorry
some-
to everybody else that's listening to my stories.